Welcome to the Explainer. Today, we are diving deep into a 2025 clinical update on alcohol use disorder. We're pulling from two really important landmark reviews in the Lancet and the New England Journal of Medicine. So let's just get right to it. So to really grasp the sheer scale of what we're talking about, let's just start with one number, a huge one. Back in 2019, it was estimated that 400 million people around the world met the criteria for alcohol use disorder. That's a staggering figure. But here's the thing, and it's a major disconnect. Even with that incredibly high number, there's this huge gap in treatment. And a lot of that comes down to things like social stigma and just not enough public funding for care. Okay, so here's how we're going to break this all down. We'll start with that global burden and the treatment gap. Then we'll look at how we diagnose this, the criteria. From there, we'll dive into the neurobiology, what's happening in the brain. That'll lead us into evidence-based clinical management, and we'll wrap up with the key take-home messages for clinicians. All right, first up, let's take a closer look at that global burden. We're going to dig into the numbers from 2019 to see what the data tells us. Right away, the data shows a really clear difference between the sexes. The prevalence in men, it's almost double what we see in women. And, if we look at a world map, this isn't spread out evenly at all. Geographically, Eastern Europe actually has the highest prevalence rates. After that, you've got parts of Latin America and Central Europe. It really points to some complex factors going on in different parts of the world. And this is really interesting. This quote from the Lancet highlights a super clear income gradient. Basically, what the data shows is that alcohol use disorder is more than twice as common in high-income countries compared to low-income countries. So there's a direct link to economic factors. Okay, so we've got a sense of the scale and who's affected. So how do we actually diagnose this? Well, the way we do it, the diagnostic criteria, have really been changing over time. One of the most important things to understand right now is that there's a split between the two major diagnostic systems. On one hand, you've got the DSM-5, which uses this single spectrum idea. It's based on 11 criteria to figure out severity. But on the other hand, the ICD-11, it sticks with two separate categories: alcohol dependence and harmful pattern of use. And this isn't just academic, it really changes how patients are classified and how we think about their care. But neither of these systems is perfect, and they both get some criticism. A big one is the lack of cultural specificity. What loss of control looks like can be very different across cultures. But it's also about an over-reliance on these behavioral checklists that aren't really tied tightly to the underlying brain science. And that's a problem because it could lead to over-diagnosis. So that brings us to the brain, right? What is actually happening on a neurobiological level? It all comes down to this really critical shift, a shift from seeking reward to just acting out of habit. So about half of the risk for AUD is genetic, it's heritable. And when you have chronic exposure to alcohol, it essentially dulls the brain's reward system. We're talking about dopamine and opioid pathways here. At the same time, it fires up the stress systems. And that's what drives this whole transition. You go from impulsive use to get a reward to compulsive use just to get some relief. And understanding that neurobiology is absolutely key because it directly informs how we should manage this clinically based on the evidence. Okay, so in the clinic, it all starts with screening. The AUD, which is endorsed by the WHO, is a really sensitive tool. But here's the big clinical takeaway, the thing to remember. Objective screening tools are often way better than just taking a patient's history. Because let's be honest, there's a lot of underreporting. And that's why there's been this huge shift toward objective biomarkers. And the one you really need to know about is phosphatidylethanol, or PEth. It's really considered the new gold standard. Why? Well, it's got high specificity and a detection window of 3 to 5 weeks. That makes it so much better for monitoring abstinence than any of the older markers we used to rely on. Okay, so let's walk through the management pathway. First, you've got to manage acute withdrawal. That starts with an assessment, using a scale like the CIWAR. For most people, a symptom-triggered approach with benzodiazepines is the way to go. But, and this is critical, if your patient has liver disease, you have to be careful. You need to avoid drugs with active metabolites, so you'd use something like lorazepam or oxazepam. After you've managed the acute phase, you move to long-term recovery. And here, naltrexone and acamprosate are your first-line options. They are both really effective at cutting down heavy drinking. But of course, medication isn't the whole story. You can't just hand someone a pill. Pharmacotherapy has to be combined with psychosocial support. The evidence is super clear on this. Interventions like AA and cognitive behavioral therapy have really strong data showing they work over the long term. All right, let's zoom back out to the big picture. the public health level. How do we tackle those huge barriers we talked about, stigma and lack of funding? Well, there are proven policy solutions. Things like increasing excise taxes on alcohol. We know that reduces consumption. And also simply controlling how available it is by putting restrictions on sales.
All right, so let's boil all of this down. What are the 5 key take-home messages for your practice?
Okay, number 1, always remember that AUD is a chronic disorder and it has a high degree of heritability. Number 2, PF is your best friend. It's the superior biomarker for monitoring. 3, naltrexone and acamprosate work, but they are way underused. We should be using them more. 4th, always think about liver safety when you're choosing treatments. And finally, number 5, medication plus psychosocial support. You need both for truly holistic care. So all this leaves us with one final, really critical question. We have this growing arsenal of effective treatments, the science is getting better, so how can we in our clinical systems actually bridge that gap between the evidence and what we do every day? How do we finally close that massive treatment gap we started with?